This program is brought to you by Emory University.
So I have the pleasure of introducing Dr. Pinney this morning, who I'm sort of forever indebted to for two reasons. Number one, for writing the editorial for my first article in JACC. I don't know if he remembers that. And second, for leading the heart failure and transplant portion of the board review course, which allowed me to get board certified in heart failure. He's been incredibly active in the heart failure community. Has served, actually did his residency and internship at the BI, and then went on to Columbia to do his cardiology and heart failure training. Has since then been at Mount Sinai and has been the director of the program there in advanced heart failure for a number of years, and more recently sort of directing heart failure within the entire Mount Sinai health system. He's also been incredibly active within AHA and ACC. He served as editorial positions within JACC Heart Failure, as well as JHLT, so really been a leader in the field for both heart failure as well as transplantation. So we're really pleased to have him here, and I hope to learn a lot from you over the next hour.
Thanks so much, Alana. It's really a terrific pleasure to be here. I was saying that on the flight down, I saw Phil Simms and Boomer Esiason, and I've been watching them on TV for a number of years. And my wife was watching it the other day, and she's like, "Phil Simms, I don't like the way he dresses." So I text her, "Phil Simms on my flight." She goes, "Tell him I don't like the way he dresses." So anyway, well, it's exciting to run into those guys, and more exciting to be here amongst friends and colleagues to talk about something I'm very passionate about, which is advanced heart failure. And so this is really an exciting time for those of us who practice in the field of heart failure. After many, many years of no advances, right now we're seeing terrific advances in a number of different areas of diagnostics and therapeutics for heart failure, including some interesting pharmacology with myosin sensitizers, with the whole field of diabetes and heart failure with the SGLT2 inhibitors, NEP inhibitors. We are seeing the advent of a number of devices, and certainly you're all familiar with the results of COAPT, showing the potential role for mitral clipping. And we're seeing transformation, digital transformation in how we manage patients remotely and in the office. But what I'm going to focus on today are some areas of innovation in a specialized field of heart failure, which is that of advanced heart failure, talking about some advances in transplantation and mechanical circulatory support. Now, it's been just over 51 years since the first human heart transplant was performed by this gentleman, Dr. Christian Barnard, in Cape Town, South Africa. And although the glory goes to Dr. Barnard, I would argue that really the fact that transplantation exists and the reason why it's successful is because the gentleman on the right, Dr. Norman Shumway, and he and his team at Stanford were the ones that really not only developed the technique, but through rigorous scientific approach, refined the surgical technique, the medical technique, and other things too. And this is Dr. Shumway performing the first transplant at Stanford. It was the fourth ever. The recipient was a 54-year-old steel worker, and just looking at that photo, he sure looks a lot older than 54, doesn't he? And this is Dr. Shumway at the press conference afterwards, and when asked, how did it go, he said, well, the heart's got a good beat, a typical understated style. So as much as we celebrate those initial forays into heart transplantation, there was a flip side of the coin, and that is that throughout the 1970s, transplantation was not really recognized as a heroic intervention, but rather was a tragedy. And this persisted because the survival after heart transplantation was really quite poor. And in those initial transplants that I mentioned, those folks only lived for 2 weeks before they passed away. And then something interesting happened. So in 1978, cyclosporin was developed and started to go into clinical trials and use at Stanford and Medical College of Virginia and a couple other places. And by 1982, it was FDA approved as immune suppression for solid organ transplantation. And look what happened. We saw a significant increase in survival, median survival going from what used to be days or months up to several years, and an explosion of heart transplantation, not only nationally but internationally, as this became the therapy of choice for advanced heart failure. And we see that there has been stepwise improvement over several decades, measured here in terms of median survival. So if you receive a heart transplant today, we're not even sure what your median survival is, but we suspect it's probably going to be a little bit north of 13 or 14 years. And if you contrast that to the mortality associated with advanced heart failure, where you're looking at anywhere between a 25 and 50% one-year mortality, to achieve survival rates in excess of 10 and 20 years is really quite miraculous. Now, one of the things that has limited heart transplantation is allograft rejection. It's something that is always on the back of our minds, and Alana and I were comparing stories last night about some of our patients who are struggling through rejection right now. So some of the good news is that with some of the medical advances, we see that most people who receive a heart transplant, it's only about 15% of those who are going to experience a significant rejection episode, something significant enough to require intensification or treatment, whereas most are going to experience no rejection or only mild forms of rejection. However, for those patients who do experience an episode of treated rejection, there's a cost that they pay. We now recognize that those individuals experiencing treated rejection within the first year of transplant have a hangover effect where they will enjoy a survival which is about 10% less than those patients who either experienced mild forms of rejection that didn't need treatment or did not experience rejection at all. And so the way that we detect rejection, and certainly the gold standard as it's been for many, many years, has been the performance of endomyocardial biopsy, starting with the development of the Caves bioptome back at Stanford and the initial pathologic grading system by Margaret Billingham, also a pathologist at Stanford. This is the way we do endomyocardial biopsies. You take a bioptome, pass it through the internal jugular vein, across the tricuspid valve, either under echo guidance or fluoroscopic guidance. I don't know, I think the echo guidance is more of a southern thing. I know they do it at Duke. I think y'all do it here too. Did you see the y'all? I'm already picking it up. And so the bioptome is positioned on the interventricular septum, jaws are open and then closed, and after the bite is taken, you leave a little bit of a divot here in the myocardium. The thing that also impresses me about this photo is it reminds me just how thin-walled that right ventricle is. It's pretty easy to poke right through it if you're not careful. So this has led to the advent of desire to find other non-invasive ways of detecting rejection. And we always joke that we give you a heart and then we take it back piece by piece. Wouldn't it be better if we could just do a blood test for rejection? We now know that there are certain genes and immune pathways that are either upregulated or downregulated at the time of a rejection episode, and that expression can be detected in circulating peripheral leukocytes, and that we can use gene expression to detect and measure RNA from the peripheral blood, either through microarray technology, and this was what was used to develop the commercially available test, or through real-time PCR to identify the expression of specific individual genes, and that this pattern of gene expression may differentiate quiescence from rejection. And so this is the AlloMap test. This is the only commercially available gene expression test, and it has identified 11 specific genes that are affected at the time of rejection. There are T-cell priming genes and mobilization of erythrocyte genes. These are upregulated at the time of rejection. And there are others which are downregulated, including those that control platelet activation, and some steroid-responsive genes are also downregulated during rejection. And then lastly, there are two other genes which were identified through microchip gene array, the role of which are not entirely clear, but they seem to be upregulated at times of rejection. Now, you can do targeted real-time PCR on these 11 genes and measure the amount, quantify the amount of gene expression, and this test will take that measurement of gene expression and transform it into an ordinal score. And that ordinal score tells us that ordinal score, the test performance, has a very, very high negative predictive value. So if you establish a threshold score of 34 and you're below that, the test performance is such that there's a very, very high negative predictive value, such that patients with a score below 34, you can be relatively certain that they're not rejecting. Now, if there's a score that at 34, above 34, all bets are off. It's not necessarily true that they are rejecting. All you can say is that that you cannot exclude rejection. So we now have over 2,000 patients who have been enrolled in clinical trials with the use of gene expression profiling. There was the CARGO and CARGO-2 observational trials, which were there to define the performance characteristics of the test, and then the IMAGE and the e-IMAGE trial, which was the translation of this test into clinical use. So IMAGE randomized about 600 patients to one of two strategies. One was the typical strategy of using endomyocardial biopsy for rejection surveillance versus a rejection surveillance program that incorporated gene expression profiling. And the way that this worked was that patients would come to their outpatient clinic visit, you'd perform a history of physical and echo, and a gene expression profiling test. And if there was no suspicion of rejection, either based on history or physical or echo, you then looked at the gene expression profiling score. And if it was less than 34, you felt pretty confident that rejection has been excluded, and they went on with medical therapy. And if the biopsy was greater than or equal to 34, that was followed by a biopsy. And if rejection, or at least significant rejection, was excluded, then you continued with surveillance using gene expression. And if it was significant, moderate to severe rejection, either 2R or 3R, then it was treated. And after a period of quiescence, they would go back to a gene expression profiling surveillance pattern. On the other hand, if rejection was suspected on clinical grounds, then that was means for a biopsy right up front. And similarly, too, if rejection was excluded, they went back to their usual rejection surveillance program. And if they had proven moderate or severe rejection, it was treated. So these are the results from IMAGE, and it showed that a strategy that employed non-invasive rejection surveillance using gene expression profiling was non-inferior to one that incorporated routine biopsies. And you can see the results over about a 3-year period or so, showing that the combined endpoint of hemodynamically significant rejection, hemodynamic graft dysfunction, death, or retransplantation was identical between those two groups. However, there were some differences, and clearly those patients who were enrolled in the gene expression profiling arm underwent fewer biopsies. In fact, about 50% of the patients who were in the GEP arm had no biopsies whatsoever. The majority had 0 or 1 biopsies per patient year, whereas those who were in the biopsy arm, it was more typical to have 2, 3, or 4 biopsies per year. And not surprisingly, too, patient satisfaction was much higher with the gene expression profiling pathway. Now, this led a number of investigators, particularly John Kobashigawa at Cedars-Sinai, to say, well, you know, one of the gaps in IMAGE was that patients were eligible for enrollment between 6 months and 5 years after transplant, but the majority were enrolled between a year and 3 years after transplant. And that's a period where the rates of rejection are a lot lower. What if we were to move this into a group that's more susceptible to rejection? And so his hypothesis was that a strategy of employing gene expression profiling early after transplant, starting at day 55, extending up to a year, that a gene expression profiling pathway would be non-inferior to one of using endomyocardial biopsy. And he had a very similar primary endpoint to that used in IMAGE, and in addition, he also looked at first-year IVUS changes. And so this diagram looks very, very similar to that in IMAGE, except for one exception, and that is because of the performance characteristics of the test, people usually have lower AlloMap scores early after transplant, and after about a year, they begin to rise. So to achieve that same negative predictive value, you have to have a lower cut point early on. So for people who were enrolled between 2 and 6 months in the study, the threshold for a positive score was at 30 as opposed to 34. And then after 6 months, it reverted back to 34. So with that one distinction, you can see that the combined endpoint of graft dysfunction with or without rejection, graft loss, either through death or the need for a repeat transplant, was identical in the endomyocardial biopsy arm as well as the gene expression profiling arm. And if we look a little bit closer, you can see that this was probably a very carefully selected population. The overall event rate was pretty low, with only 10-15% event rate in the two arms. There was no evidence of death or retransplant regardless of the arm that they were enrolled in, and that most of the endpoints were met because of graft dysfunction. But there were significant differences in the number of biopsies performed. So there were about 250 performed in the biopsy arm, only 42 in the gene expression profiling arm. And this comes out to be about 8 per year for patients who are followed in a traditional way versus about 1.4 per patient year for those with undergoing gene expression profiling. And although there was no difference in the primary endpoint, as you would expect, patient satisfaction was much higher. And importantly, there was no difference in the rate of intimal medial hyperplasia detected by IVUS in the two arms. So we were pretty excited about the use of gene expression profiling many, many years ago. So I was a little bit gun-shy to just kind of jump in. So in 2007, myself and my colleagues, we decided to do simultaneous biopsies and gene expression profiling in our patients who came through the biopsy suite. And we enrolled about 123 patients who had both endomyocardial biopsies and AlloMap testing done. We had a total of 140 matched samples. And this was mostly an older population further out from transplant. We only had about 6 patients who were between 6 months and 12 months, which as a rate was even less than that in image. And this was our initial experience, low sensitivity, low specificity, but what we focused on was the negative predictive value. And the test performed pretty well in our center with a negative predictive value of almost 98%, a little bit less than what we saw in the cargo study of 99.2%. And this gave us a little bit of a pause. We looked at our performance characteristics of the test. We had an ROC value of about 0.66, I think it was. So it was better than a coin toss, but didn't reach the performance characteristics that we were quite ready to go all in. So then we recognized that there's tremendous inter-observer variability when you're scoring pathology samples, and not only is there inter-pathologist variability, there's also intra-pathologist variability, and that came out in the Cargo 2 trial, that when you take the same biopsy and you blind the pathologist and you wait and you send it back to them for a second read, that oftentimes they even differ with their own reading. So I went and spoke to our pathologist and pulled out 5 of the cases that we recognized had significant rejection. And one of those was eosinophilic myocarditis, and so we excluded that. And then we had 4 cases of 2R rejection. And of those, most of them were late after transplant with a median of 3 years after transplant. All of them were hemodynamically stable, normal hemodynamics, normal echo. 2 of the 4 had an AlloMap less than 34, which raises the question, if you believe that gene expression is a better marker of what's happening mechanistically, maybe those were overreads. And one of the 4 biopsies really should have been classified as a 1R, because as I reread it with a pathologist, they said, yeah, this is really a 1R, not a 2R rejection. So we felt a little bit better about using it, and then we had some technical issues around where can patients get their blood drawn, and so we had a little bit of a gap. But a few years after that, we started incorporating into our rejection surveillance protocols where we would consider using it at earlier and earlier time points. And then by 2018, we had enough of a sample that we went back to look at our performance. And so what we found is that about 3/4 of our patients are having gene expression testing performed. And then we did a total of about 450 tests or so. And most of these are being performed in the period between 6 months and 12 months. We have a few, myself included, who will put our toes in the water and start using gene expression profiling instead of a biopsy in carefully selected patients 2 to 3 months after transplant. And there were a few that will use it late after transplant, but the majority of our use is in that 6 to 12-month period. And so then we looked at the distribution of AlloMap scores, and one of the things that we had recognized was that we seemed to have a lot of 34s. I'm like, really? You kidding me? It's right on the line. You're tempted to defer the biopsy, but we stuck to it that if it was 34 or higher, we would do a biopsy. And so sure enough, about 25% of our patients had an AlloMap score which was at or above the threshold. And of those, only 1 had a subsequently positive biopsy. And more importantly, none of the patients who had an AlloMap score of below 34 subsequently had to go and have an unplanned endomyocardial biopsy because of suspected rejection. So we also looked at our early experience. This was a limited experience, only 12 patients who had started gene expression profiling instead of endomyocardial biopsy. Only about 1.3 tests per patient. And there were 3 persons who had a score greater than 30, which triggered then a biopsy, but none of those had confirmed 2R or 3R rejection. So we are using gene expression profiling early after transplant. It hasn't had the same traction with some of my more senior colleagues, but nonetheless, I think my junior colleagues see the advantage of using a strategy like this. And I think that there are now other applications that we can use for non-invasive detection of rejection. One of them is to look at score variability within the AlloMap score, which I'm not going to talk about. And the other is to combine it with what I think is really exciting right now is the presence of donor-derived cell-free DNA. So what is cell-free DNA? Well, all of our cells in our bodies turn over at a certain rate, and they release free-floating DNA into the bloodstream. And the expression or the quantity of cell-free DNA circulating in the bloodstream goes up whenever there is injury or inflammation. Nonetheless, in a quiescent state, the amount of production of cell-free DNA is relatively stable and can be detected in a couple different ways. Now, if you think about it, when you do an organ transplant, you're not just transplanting a solid organ, you're also doing a genome transplant. And so you're taking a donor heart with a specific set of DNA, and you're transplanting into a recipient that has a different DNA pattern. And both of those, both the host and the donor organ, have a fair amount of cell turnover. And therefore, whether one uses a shotgun approach or a targeted approach to detecting cell-free DNA, you can discriminate between donor-derived cell-free DNA and recipient DNA. And that ratio of the expression of one over the other tends to be relatively stable and fixed over periods of quiescence, and it increases in the setting of injury, inflammation, or in this case, allograft rejection. So this is an example of one patient who had donor-derived cell-free DNA testing, and you can see that the ratio of donor-derived to recipient DNA is relatively stable over time. It certainly goes up right after the time of transplant because there's a lot of injury and inflammation in the allograft, which releases donor-derived DNA. However, very quickly, within a month or so, it goes down to a baseline value, and that ratio remains stable throughout periods of quiescence. Now compare that to the example down below where you can see a person who is stable throughout the first 5-6 months of transplant and then experience an episode of severe allograft rejection. And the ratio then of donor-derived cell-free DNA to recipient DNA went up significantly. Unfortunately, they did not recover from this rejection episode, had to undergo a second transplant. And again, you can see the ratio of donor-derived cell-free DNA to recipient DNA is very, very high after the transplant and then drops down to a steady baseline. Now, this is true for cellular rejection, but more importantly, it's true for antibody-mediated rejection too, such that we now think that these two tests can be used in complementary fashion, where gene expression profiling may allow you to exclude acute cellular rejection. The presence of an increase in donor-derived cell-free DNA may allow you to detect antibody-mediated rejection. So we went back and did just a preliminary look at some of the samples that were stored in cargo. They selected 8 patients who did not have rejection, 9 patients who did have rejection, and measured the quantity of donor-derived cell-free DNA. And you can see that on average, those patients who experienced rejection had much higher levels of donor-derived cell-free DNA as compared to those patients who were quiescent. So armed with this new molecular diagnostic technique, there are a couple studies that are ongoing to take a look at this in a little bit more detail. So one is a observational database called OR, and in that is a sub-study. And in that sub-study are patients who consented to have donor-derived cell-free DNA measured. And then the second is Shear, and this is going to be a prospective observational database using donor-derived cell-free DNA in combination with gene expression profiling to define antibody-mediated rejection and acute cellular rejection. So this is data, some preliminary data that's now currently out for publication, looking at the D-OR experience. And you can see here on the bottom are those patients who experienced no rejection, acute cellular rejection, antibody-mediated rejection, or mixed rejection, both acute cellular and antibody-mediated. And you can appreciate that there is a stepwise increase in the expression of donor-derived cell-free DNA in those patients with antibody-mediated and mixed rejection. So let me pivot and talk a little bit more about what I think is a really exciting development, which is focusing on attempts to block interleukin-6. Now, interleukin-6 is a pretty interesting inflammatory molecule that has very pleiotropic effects. The things that are salient for us who practice transplant medicine is its effect on the hepatocytes, which is responsible for making a number of inflammatory cytokines like CRP, fibrinogen, serum amyloid A, and hepcidin, and also decreases the production of albumin. So many of you have made the observation, I'm sure, that when your patients get hospitalized, particularly in the setting of infection or other inflammatory states, their albumins all drop to about 2.5 or 3, and one of the reasons for that is that direct effect of interleukin-6 on the liver. It also has important effects on T cell signaling and also B cell production, with forcing sensitized or activated B cells into becoming antibody-producing plasma cells. So one of the things that we know is that interleukin-6 has a significant effect on driving T cell morphogenesis. And what it does is it tends to block the production or the differentiation of naive T cells into regulatory T cells or Tregs, which are responsible for promoting tolerance and preventing alloimmunity. And instead, it directs it more towards the effector arm of the T cells with the production of Th1 and Th17 T cells, which are cytotoxic T cells and play a pathogenic role in autoimmunity and also allograft rejection. And also, they play a role in making those sensitized or activated B cells, transforming them into antibody-producing plasma cells. Therefore, it's an interesting concept that if we can block interleukin-6 in transplant medicine, we may be able to do a couple different things. First, by removing the effect of interleukin-6, we can shift the differentiation of T cells towards Tregs, promoting tolerance and preventing autoimmunity. And we can decrease the effector arm by decreasing the cytotoxic T cells and preventing antibody production. So tocilizumab is a humanized monoclonal antibody which is directed at the interleukin-6 receptor. And the interleukin-6 receptor exists both in membrane-bound forms and also free-floating forms in the serum. And this drug is currently FDA approved for treatment of refractory inflammatory diseases such as rheumatoid arthritis and JRA and Castleman's disease. And it's shown impressive efficacy in RA patients who had failed to respond to first-line disease-modifying anti-rheumatic drugs. So its use in transplantation has been right now mostly confined to renal transplant. This is one study showing its effect on decreasing circulating alloantibodies in patients who are highly sensitized and awaiting a renal transplant, showing that DSAs, donor-specific antibodies, were essentially eliminated in all but one patient, and that patient had 2 very weak DSAs, but no proven antibody-mediated rejection. And in those patients who have chronic antibody-mediated rejection, again, renal transplant patients, the use of tocilizumab as opposed to standard of care promoted higher rates of graft survival and higher rates of patient survival compared to standard of care alone. So we are excited about the use of this molecule, the use of tocilizumab in heart transplantation, in part because we think it can promote tolerance, it can decrease the amount of rejection, it can also decrease the amount of antibody production, which may then translate into not only lower rates of antibody-mediated rejection, but may also reduce the rates of cardiac allograft vasculopathy, which is one of the long-term risks of heart transplantation and can lead to late graft loss. So this is now an NIH-sponsored and approved trial called the Targeting Inflammation and Alloimmunity with Heart Transplant Recipients with Tocilizumab. It's got the best acronym that I know of. It's called All-In, which is kind of clever. Joran Madsen from Massachusetts General Hospital is the PI, and Dr. Kabashigawa from Cedars is the protocol chair. And this is a phase 2 multi-center clinical trial which hopes to enroll 200 heart transplant recipients. They will be enrolled while they're on the waiting list, but they will not be randomized until after they've received a transplant and are hemodynamically stable, at which point randomization will occur to either treatment with tocilizumab in combination with triple immune suppression or placebo plus triple immune suppression. And those who get tocilizumab will get up to 6 doses given once every 4 weeks over a 20-week period. And the primary endpoint is going to be a combination endpoint looking at the production of de novo donor-specific antibodies, either acute cellular rejection or antibody-mediated rejection, hemodynamic compromise in the absence of rejection, death, or retransplantation. So this trial has been launched. We are one of the enrolling sites, and so we are looking for our first patient to enroll in the study. MGH, I think, was the first to enroll one patient, so I think there are only like 2 in the trial right now. And as of our conference call last week, no patient has yet been randomized. So stay tuned for this. So I talked a little bit about the success and some of the limitations of heart transplantation, and I think this one slide sort of sums it up, which is that following that initial explosion of heart transplantations throughout the 1980s, you've seen that the volume of transplants in the United States has really plateaued at about 2,200 heart transplants per year. And so in order to increase that volume, I think there are a couple different things that we're going to need to do in order to provide care to these advanced heart failure patients. So one is to consider using ex-vivo perfusion. This is the organ care system, which is essentially a Langendorf that has been converted into a support system to allow warm perfusion so that the heart can remain perfused with its own blood and remain beating during transport. Now, this has allowed transport over a longer period of time. It has allowed longer periods of warm ischemia and shorter periods of cold ischemia. This device is not yet currently FDA approved for heart transplantation, but it is FDA approved for lung transplantation. And one of the interesting things, or one of the nice things about this technology, is that you can sample off lactate levels while you are transporting or while you are supporting the organ, and you can identify those hearts that have high lactate levels that probably should not be transplanted. But you can also use this as a resuscitation device. And so a heart that may be initially compromised can be put on the care system. You can follow the lactate levels, and if they are high and they become low, or if they remain low, then you can feel confident that you can go ahead and transplant that organ. So this is looking at the PROCEED data, which was a randomized trial using the organ care system. This happens to be a single center experience at Cedars-Sinai looking at 2-year outcomes. And you can see that the survival of patients who were transplanted with the organ care system out over a 2-year period is no different than those patients who were transplanted with an organ that was transplanted with the standard of care, which right now is cold storage, which is packing it on ice and carrying it in an igloo cooler. So for something that has existed for 50 years, I think we can do a little bit better than just a cooler. And so this is a pretty exciting technology. And I think where it may lend its best application in the United States is not so much traveling longer distances to get organs, but rather to consider the possibility of donation after cardiac or donation after circulatory death. In general, I'm always reluctant to consider transplanting from a donor where cardiac death is the reason why they died, as opposed to brain death. But if you think about it, the very first heart transplant was a DCD donor. And so if one can envision a scenario where you have a DCD donor, you can go ahead and harvest that allograft and put it on the organ care system, be confident that the lactate levels are not increasing, we may be able to increase the amount of organs that are harvested. So my colleague at Columbia, Jane Farr, and she and others within our transplant consortium, we just did a hypothetical, and we looked at all of the DCD donors in New York over a several-year period, and we looked at of those, who would we consider to be an ideal donor? And what we found is that there were opportunities from a process viewpoint to do more echoes, but that if one were to do more echoes in selected donors, there were potentially about 100 donors per year that could be identified through DCD donation, which is really quite remarkable. So again, this is a little bit preliminary, a little bit innovative, but I think we're going to be hearing more about this over the next 5 years. Well, let me turn to what I think is probably the most significant innovation in the last 10 years, and that is the evolution of ventricular assist devices from the first generation large pulsatile volume displacement pumps to the continuous flow second and third generation devices. And with these devices, we've seen significant improvements in survival and patient quality of life. And there are right now 3 devices which are in clinical use and which are approved by the FDA. The first is the HeartMate 2. This is the one that was the first continuous flow pump to be approved. This is an axial flow pump, and it gets its name because the flow is along the long axis of the rotor. And this impeller is essentially an Archimedes screw, which spins at around 9,000 revolutions per minute. It's suspended by 2 contact bearings, and it basically bores into the blood volume coming from the left ventricle. It can generate blood flow of anywhere between 3 and 10 liters per minute, and is approved for both bridge to transplant as well as destination or lifelong therapy. This is the hardware, I guess it's now Medtronic HVAD, which is the same concept, which is that you have a single moving part, but this is a rotor which is suspended both hydrodynamically and also electromagnetically with no contact bearings. This is called a centrifugal pump because the blood comes in and it is radially accelerated before it is expelled out the outflow graft and returned to the aorta. Now, one of the other design characteristics which is different for this type of pump as compared to the HeartMate 2 is the fact that it is completely contained within the pericardial sac, and it doesn't require the creation of a preperitoneal pocket below the diaphragm. Now, when you compare these 2 pumps side by side, there are only a few comparative efficacy trials. The reality is that when you focus on the things that matter most, which is can you keep people alive, the one pump is non-inferior to the other. They do what they're supposed to do, which is to keep people alive. And when we compare the HeartMate 3, which I'll talk about in a minute, to the HeartMate 2, similarly so. There's no difference in overall survival between these pumps. So if you use the transitive property, HeartMate 2 is equivalent to HVAD, which is equivalent to HeartMate 3 in terms of survival. But where these pumps differ really is in their adverse event profile. And so there are several adverse events that are associated with these pumps. I think 3 of the ones that we all struggle with the most are bleeding, particularly mucosal bleeding from either the nose or from the gastrointestinal tract, which arises kind of for something very similar to Heide syndrome with decreased pulsatility leading to the development of arterial venous malformations, combined with an acquired form of von Willebrand's syndrome, where the large multimeric forms of von Willebrand factor are degraded through shear stress as they go through the pump. Stroke, both ischemic and hemorrhagic stroke, and then pump thrombosis, and this is an example of a thrombus that developed on the inflow contact bearing of a HeartMate 2 device. So when you put all this together, there are clearly some patient characteristics, there are pump characteristics, and there's also pump programming characteristics that really influence what Mandeep, with his typical way of turning a phrase, he now refers to as the complex weave of hemocompatibility, which means that if you try to affect one arm of hemocompatibility, then you also may adversely affect the other arm. So for example, years ago, we started saying, well, you know, we're seeing a lot of bleeding. What if we were to just lower our INR target? That would make a lot of sense because 30% of patients were being rehospitalized because of bleeding. And then we said, well, you know, AVMs are created because of, you know, lack of pulsatility. Maybe we should turn the pump speed down in order to give patients back a little bit more pulsatility. And then that was followed by this recognition in 2012 that pump thrombosis rates all of a sudden skyrocketed. So whether it was related to how we programmed the pump and whether it was related to how we prescribed anticoagulation or whether it was something in the manufacture of the pump, I don't think we'll ever know. But clearly all 3 of those factors do come together to influence clinical outcomes. So we're looking for different ways that we can overcome these adverse events. So one of them is to wash the bearings or wash the pump. This is the Lavari cycle on the HVAD device. And Lavari, for those of you who are Latin scholars, means to wash. And it is a cycle where every 60 seconds the pump will reduce its speed by about 200 revolutions per minute, hold it there for a few seconds, over-accelerate, hold it at a higher rate for a second, and then drop back down. Now, the reason to do this is not to create an artificial pulse that you can feel, but rather it's to disrupt the flow through the pump so that if there are any flow eddies that are developing or if there are any areas of stasis, it gets washed out every minute so that you don't form a clot there. Now, there's been no prospective trial of this programming feature, but there is a database of the use of the Lavari cycle in Europe. There were about 400 or 500 people who had the Lavari cycle turned on and about 33 people who had it turned off, so not quite an equal comparison, but if we were to look at survival, patient survival measured out over a year, there was no difference whether this cycle was on or off. One would not expect much of a difference, but because what was really the reason behind this programming was to try to decrease adverse events. And there is at least a small signal that the rates of stroke and GI bleeding were less in those patients who had this intermittent programming, lower rates of sepsis, and maybe also lower rates of right heart failure. None of this prospectively tested, but certainly an interesting hypothesis. And I don't know about whether or not, I know you put in a lot of HVADs, whether you're using the Lavari cycle or not, but I think it's now present and all you have to do is hit a button, you can turn it on. And that brings me to the HeartMate 3, which is the most recently approved ventricular assist device. This, like the HVAD, is a centrifugal pump, but it has a couple design characteristics which were there specifically to try to mitigate some of those adverse events around hemocompatibility. So the first is that there's a wide gap between the rotor and the wall of the housing so that the blood that's entrained undergoes less shear stress. It's completely frictionless because the device is completely elevated magnetically, and this full magnetic technology is thought to prevent the rotor from pitching, from rolling or yawing, for those of you who are a pilot, so that it doesn't make contact with the wall. And by doing that, it doesn't create areas where it increases shear stress. And then lastly, it also has an intrinsic pump similar to the Lavari cycle, although the programming is a little bit different. So this compares shear stress between the HeartMate 2 impeller and the HeartMate 3 impeller. You don't have to be a scientist to recognize that lower shear stress is reflected in blue. It's nice and cool, and you can see that as the blood goes through the pump, there are lower areas of shear stress. Compare that to the higher shear stress that blood encounters as it goes through the HeartMate 2 impeller, and you can see that the highest rates of shear are right there along the impeller blades where the shear stress goes up significantly, and we think that's where most of the hemolysis occurs. And this is the programming for the HeartMate 3. As opposed to cycling every minute, it cycles every 2 seconds. And so with a lot of the patients, you can feel an intermittent pulse as the pump slows its speed, allows for greater left ventricular filling, and then increased contractility. But although you may or may not feel a peripheral pulse, the reason behind this programming, again, was to wash the internal component and not to create pulsatility. So we just saw the publication and the presentation of the long-term cohort of the Momentum 3 study. This was presented last year at the ACC in Orlando. This was a 2-year follow-up of 366 patients who were randomized to the active pump, which was the HeartMate 3, versus the control pump, which was the HeartMate 2. And this is the primary endpoint analysis according to intention to treat, which is survival at 2 years free of major disabling stroke, which was defined as greater than 3 on the modified Rankin scale, or reoperation to replace or remove a malfunctioning device. And you can see that at 2 years, about 78% of patients who received the HeartMate 3 met the primary endpoint, as opposed to about 56% with the HeartMate 2. And this was not only a non-inferior trial, but was actually shown to be superior, the HeartMate 3 to the HeartMate 2. So in subgroup analysis, this benefit seemed to extend across all subgroups, regardless of age, gender, race, intended use, and how sick they were, their Endomax profile. And importantly, not only did the pump improve survival, but both these pumps, the HeartMate 2 and the HeartMate 3, improved functional capacity with early and sustained improvements in functional capacity. and also quality of life, which was measured by the EuroQol 5D test. And I think it's important to say that because while it is important to improve survival, if you're not improving survival and improving quality of life, then you're just prolonging suffering. So I think both these pumps succeed in improving functionality and quality of life. And so the devil, of course, is in the details, and what we want to look at is how did these two pumps compare in terms of their effects on adverse events. Probably the thing that is most striking is that the development of this new pump essentially eliminated one of the major adverse events, which is pump thrombosis. And although there was one case report of a pump thrombosis with the HeartMate 3, it was really clot that got sucked into the device rather than anything that developed de novo in the device. So those engineering features have really translated into clinical benefit. Also, we're seeing differences in the rates of stroke compared one device to the other, but no differences in gastrointestinal bleeding. You can see that the rates are still quite high, with 27%, or basically 1 in 4 patients experiencing gastrointestinal bleeding. So it's, it's exciting as it is to think that we've reduced the risk of stroke. I think if we take a closer look at the incidence of stroke in the HeartMate 2 versus the HeartMate 3, this figure actually comes from the appendix and is not in the main text. You can see that the majority of events that were reduced were minor strokes. Those are the ones that are here in green, which are non-disabling strokes, but very similar rates of major disabling strokes between the two pumps. So yes, there has been some benefit, and I'm not going to downplay reducing minor strokes. And in fact, Dr. Colombo presented some data at the Heart Failure Society showing that if you look at that group of people who experience minor strokes, they subsequently had adverse survival over the next year or two compared to those patients who didn't have a stroke. So any type of stroke is bad, but most of the reduction of stroke in the Momentum 3 was in minor strokes. And as I mentioned before, we've essentially eliminated one of the major adverse events of this technology, which is pump thrombosis. And you can see that there was almost no cases of pump thrombosis in the HeartMate 3 arm. So I hope I've had a chance to share with you some of the excitement I think that exists in the field of LVAD and transplantation. Currently, I personally am involved in these molecular diagnostics and also with the Tocilizumab trial. I think that both of these have an opportunity to not only improve graft survival, patient survival, and decrease the rates of rejection, but also to significantly improve quality of life for patients with transplantation. Mechanical circulatory support, as we were talking about last night at dinner, is going to continue to be the growth area for the field of advanced heart failure. Living through that introduction of the first pulsatile pump in clinical use, and then seeing patients just miraculously do better with the continuous flow pumps was really quite something for my own career. But when I think about what's the next paradigm shift, and I think it's going to be, implantable, fully implantable, durable, adaptable biventricular assist device, which is going to be a total artificial heart. That type of paradigm shift is still many, many years away. So I think the focus of technology, focus of research is still going to be how do we improve, how do we tinker, how can we make these continuous flow pumps a little bit better so that our patients do better. So again, I'd like to thank you for inviting me here this morning. I hope that I left a few minutes for questions. It's a tremendous pleasure to be here and meet new friends, and happy to take some questions from you. Thank you.
So we were talking last night about the change in allocation system.
It's always the challenge.
There we go. We were talking last night about the change in the allocation system and how the system has obviously sort of pushed us more towards transplanting the sickest patients first, which obviously sort of makes us all aware of our outcomes and the fact that we're doing these procedures in patients who are risky going in. Has that changed at all the way that you think about doing the AlloMap post, particularly in that early sort of 2 to 6 month period? Because we're, at least from what we've seen, it sounds like you guys have had the same experience so far. All the transplants have been the status 1, 2s, and 3s, who are already sort of higher risk for bad outcomes post-transplant anyway. So has that changed? Do you guys' management style at all as related to AlloMap?
No, that's a great question. No, it hasn't. I think that the patients we would consider for early use of AlloMap are those patients who didn't have evidence of 2R, 3R rejection early after transplant. And then there's also some profiling. I think that if we were to do it, we would do it with great caution in young, multiparous women. They have higher rates of allograft rejection, as you know. We might be more likely to do it in older gentlemen where the rates of rejection tend to be a little bit less. But although they're sick when they go into transplant, by about 2 months after transplant, they should be, if they're hemodynamically stable and haven't been experiencing rejection, then they should be okay for a non-invasive rejection surveillance program. Yes.
Just a question about the trial that you're starting with the IL-6 receptor antagonist. What have been your sort of thoughts about the side effect, particularly the immunosuppressive infectious risk of that versus traditional protocols?
Yeah, so that is the Achilles heel. So if you're taking out the effector arm of the immune system with removing those cytotoxic T cells, then there's a reason why our bodies over millions of years of evolution have developed this system, and that pro-inflammatory cascade is sort of an emergency response signal that the body sends out, particularly in response to infection. And so one of the Achilles heel will be infection, I think particularly fungal infections. But the other thing that we're recognizing is that you can have reactivation of hepatitis. So for patients who are hepatitis B or hepatitis C positive, they would be excluded from this trial because the risk is significant that they could reactivate. So I think infection is something that we're going to have to look at very, very closely. And that is transplant medicine. You know, it's always a trade-off. You can suppress the immune system and you can show that grafts do really well and you can completely get rid of rejection, but then you lose patients to infection. And vice versa, you can cut your immune suppression back so that patients aren't getting infected, but then you run the higher risk of rejection. So finding that right balance has always been sort of the art of transplant medicine. It will be true for this too. Yeah.
That was a great talk, thank you. My question is about patients who've had exposure to cardiotoxic medications for cancer therapy, such as anthracyclines that cause irreversible damage, as you know. Can you talk about transplant in these patients? Are these patients more likely to get rejection? Are these people not as likely to get transplant? I would love to know more. Thanks.
Yeah, it sounds like you've been visiting the transplant selection meeting. This is something that we debate quite a bit because, you know, we're always compelled to want to help cancer survivors just because of the path that they've gone down with having one life-threatening illness and then have it replaced by another. The presence of anthracycline toxicity in and of itself shouldn't prevent doing organ transplantation, but the thing that always gives me pause is when you have anthracycline toxicity in men or women who are treated, predominantly women who are treated with radiation. And it's really the radiation which makes transplant so difficult, more so on the surgical side because all the tissues are densely adherent, they're stuck, they're fibrotic, they bleed, you can tear the pleura, you can get into all kinds of problems. So they tend to be very high-risk transplants in part because of the technical challenges. But if you were to just focus on cancer survivors and look at their long-term outcomes, you know, it's always been my impression that they face a higher risk of subsequent malignancy down the road in the setting of immune suppression. We have some guidelines from the ISHLT about appropriate selection of patients after they've been treated for cancer. There is no absolute time period that you have to wait, but you have to be reasonably certain that they're cancer-free before you would go and transplant them. I'll just refer you to a really nice article that was authored by my colleague, my mentor, Dr. Donna Mancini, and it was published in JACC a little over a year ago, and she very nicely, she wrote the accompanying editorial to the article, but she very nicely summarizes the risk of malignancy and malignancy development in transplant recipients. And if you think about it, those are the things that really limit long-term survival. Acutely, it's rejection, but long-term, it's infection, malignancy, graft vasculopathy, and then something that we struggle with, and I'm sure you do too, which is renal failure after transplant. So we still have a long way to go.
I think that, as we initially were looking at some of the AlloMap data, the question was, how does that apply to our population of patients? And in part where we had differed nationally was in the percentage of African-American patients that we have. So some of these newer tests, when they come out, there's a discomfort among programs and suddenly changing. We've made some substantial changes in what we've been doing. The other thing that comes up in talking even with our colleagues in kidney transplant is that there's such a focus on the 1-year and 3-year outcomes with transplant. So, 20 years ago, 83% was the national survival. Now it's 90%. And if you start getting below that, then you can find yourself in a difficult situation where you tighten up your criteria. So the focus has been on 1 year, but if you look at what happens out at 7 and 10 years, there may be some other things that are predictive or may be predictive of outcomes, and that's the development of donor-specific antibodies and that type of things, and where there do appear to potentially be some racial differences. Alana has actually done quite a bit of work in that. But I guess my comment is that this is hard stuff, and it's not getting any easier, even though there's been dramatic improvements in a number of things. Our situation related to the related to the recipient population and what they're going through to get a transplant is much more difficult than it was 10 years ago. The VADs have been a great advance, but struggling with when do you put a VAD in and you're committing somebody to that therapy for a long period of time. But this work that you're doing is very, very interesting and very, very helpful.
Thank you. I'll respond to a couple of those comments. The first is the concern around minorities, African Americans, Hispanic Americans. That was certainly our concern too. And when I look at our population, we care for a community in Central Harlem and in Spanish Harlem, and about 35–40% of our recipients are minority recipients. So similar concerns, although the demographics may be a little bit different, similar concerns about rates of rejection in minorities. And so I was looking for one of my backup slides. I deleted it this morning, but when we did that analysis of our initial AlloMap experience, we were somewhat concerned also about risk of rejection in minority patients. And when we looked at it, it turned out not to be a predictor of rejection or a positive AlloMap test. And we subsequently have looked at the OR database and other CareDx databases and have shown that there's no difference in the performance of the test or in the rates of rejection or graft loss in patients who are followed with gene expression profiling. So I feel much more confident, having used the test now for more than 10 years, that I can rely on it. I will say anecdotally, it does seem that we see higher scores in African Americans and in some of our Hispanic patients, but none of them have had significant rejection with one of those higher scores. And if they consistently score, let's say 34 or 35, then what we do is readjust our baseline. We say, okay, your new baseline's 35, so we won't biopsy unless you're 36. And I think that's legitimate to do. I think your other comments definitely resonate with me. I think that 1-year survival benchmark, while I completely applaud the desire to drive performance improvement, I think that UNOS is, and having served on UNOS and the MPSC, I think they've come to the realization that this Hawthorne effect is not necessarily being driven by improvement in in performance, but it's in patient selection and denying people transplant. And I'm very proud to say that our center has always had a very aggressive posture towards transplant. I think if you look at our 1-year survival over the 20 years that the program is, well, it's 25 now, in existence, it comes out to be 83, 84%, which is very similar to the way it was many years ago. And I think that's because we just tolerate higher risk because we think it's the right thing to do. We also have paid a penalty for that. You know, if you list in transplant patients where you think that the 1-year survival is going to be at 80%, there's clearly a survival advantage for that patient, but you put your program at risk. And we outperformed for many, many years, but eventually those numbers, those statistics, just by pure probability will catch up to you, and it caught us. And so what I'm proud, though, is that we still didn't change our posture. I like to think about Pete Rose. He said, you know, when you go into a hitting slump, don't change your swing. You may change your position in the batter's box, you know, stand a little closer to the pitcher, maybe go back a little bit, maybe go a little closer to the plate or come, you know, away from the plate, but don't change your swing because that's what got you to the bigs. And so that's been our approach, which is like, we'll make sure that we're doing the right thing. We'll make sure that we've got the right policies and procedures and we're actually doing what we say we're supposed to do, but we're not going to change our swing because I think that, you know, transplantation was born out of, you know, innovation, was born out of risk-taking. It is truly life-saving for people who have no other option, and I think we'll continue to have that aggressive posture. I think I'm a few minutes over, but again, I want to thank you for this really kind invitation. It's a great way to start off the week, and look forward to meeting with some of you over the course of today. Thanks so much.
The preceding program is copyrighted by Emory University.